Now let us see about primary open angle glaucoma. This reference is from khurrana. It is a progressive optic neuropathy which increases in prevalence with increasing age. The risk factors are increase in IOP, aged persons greater than 60 years to 70 years, and in race blacks get more open angle glaucoma than white. And then family history, a positive family history. Then central corneal thickness is less than 555 mu m, and the characteristic of optic nerve head is such that the cup disc ratio is high. Myopia, diabetes mellitus, low blood pressure increase the chance of open angle glaucoma, and thyroid. Then migraine, sleep apnea. Pathogenesis of the rise in IOP. The decreased aqueous outflow. The sites are trabecular meshwork and the Schlemm's canal. Causes may be the foreign material in trabecular meshwork, loss of endothelial cells, loss of giant vacuoles, reduction in pore density and size. Because of the reduction in pore density, the aqueous may not be able to flow outside, and it results in improper drainage. The mechanism of changes in aqueous outflow system. Theory of acceleration of aging process. Immunogenic mechanism, altered corticosteroid mechanism, dysfunctional adrenergic control, oxidative damage, and toxic influence of TGF. The pathogenesis of optic neuropathy is due to retinal ganglion cell death. There is no transport of neurotrophins. As a result, there is cell death and apoptosis of the cells. It means cells die and are engulfed by the neighboring cells. Etiology. First is mechanical theory, in which if there is a rise in IOP, the lamina cribrosa separates into high and low. As there is a pressure difference, there occurs translaminal. The pressure difference between the high and low in anterior and posterior surface is called translaminal pressure, and as a result central spinal fluid pressure decreases. The second one is vascular insufficiency theory. Here there is failure of autoregulatory mechanism of the blood flow, and vasospasm where there is low perfusion, and BP nocturnal dips in patients with night and on taking antihypertension drugs. Secondary insults are toxic like glutamate and O2 free radicals. And the clinical features of open angle glaucoma are: first, its symptoms. It is a sneak thief of sight. Without our knowledge, the sight gets gradually reduced. Headache and eye ache. Scotoma. Difficulty in reading and close work. Next symptom is halos vision and discomfort, delayed dark adaptation, loss of vision and blindness. Signs include RAPD, pupillary reflex becomes sluggish, IOP changes, observation of IOP every 3 to 4 hours. This is diurnal variation test. That is observation of IOP every 3 to 4 hours. The IOP changes. Then IOP falls in the evening for open angle glaucoma. Optic nerve head changes can be seen. Direct ophthalmoscopy, slit lamp using plus 90 diopter or plus 70 diopter lens. Confocal scanning laser topography, that is Heidelberg retinal tomography, is also helpful. Then OCT and polarimetry. Vertically oval cup and the loss of neuroretinal rim or the early changes. Asymmetry of the cup with a difference in ratio of 0.2. Large cup, that is 0.6 CDR or more. Then splinter hemorrhage and pallor areas. Atrophy of the retinal nerve fiber layer. Late changes include marked cupping, thinning of neuroretinal rim, crescentic shadow, thickest to thinnest of the nerve fiber is in the order of Eisen to rule, that is inferior, superior, nasal, and then temporal. This is the order of the nerves from thickest to thinnest. Then there is notching, nasal shifting of the retinal vessels, and if it is broken, it is called as a bionating sign. Pulsation of the retinal arterioles, lamellar dot sign. This is a picture of the bean pod cupping, that is A, and the disc photograph in B. Next, coming to the visual field defects seen in open angle glaucoma. The distribution of the retinal nerve fibers. Fibers seen from nasal half of the retina come directly to the optic disc as superior retinal fiber and inferior retinal fiber. Fibers from the macular area come horizontally as papillomacular bundle. Then fibers from the temporal retina come above and below the macula as superior arcade fiber and inferior arcade fibers. Here you can see the diagram. Fibers from the nasal half of retina come directly as superior retinal fiber and inferior retinal fiber. From the macula it comes as papillomacular bundle. Then from the temporal retina it comes as arcade fibers. The field defects, the first one is isopter contraction. It refers to a constriction of the central as well as peripheral field. It is the earliest defect that can be seen. The next defect is the bearing of blind spot. This means there is exclusion of the blind spot from the central field due to the inward curve of the outer boundary of 30-degree central field. Here you can see the bearing of blind spot. Except blind spot, there exists a field of vision. Next is small wing-shaped paracentral scotoma. It appears either above or below the blind spot between 10 and 20 degree of fixation point. This is a paracentral scotoma where 10 to 20 degree apart above or below the arcade fibers there exists a scotoma. Above or below the blind spot in Jerem's area there occurs a scotoma. With the passage of time, the paracentral scotoma joins with the blind spot to form a sickle-shaped cedal scotoma. Here you can see that the paracentral scotoma and the blind spot has joined together to form a cedal sickle-shaped scotoma. The next one is the arcade or Jerem's, and the next one is the ring or double arcade scotoma. Arcade scotoma means the extension of the scleral scotoma either above or below the fixation point to reach the horizontal line. Here you can see the extension of the cedal scotoma to reach the horizontal line either above or below the fixation point. This is called arcade. Double arcade scotoma means when two arcade scotomas join together, it is called double arcade scotoma. Rene's nasal step is created when two arcade scotomas run in different directions and meet to form a sharp right angle defect at the horizontal meridian. These two arcade scotomas meet and they form a right angle defect. A small gap is there. That is called Rene's central nasal step. Then peripheral field defects occur at the later stage where only tubular field of vision exists. This is the whole diagram. This is bearing of blind spot. This is paracentral. This is cedal. This is arcade and double arcade and central nasal step.